This video demonstrates creation of a leg arteriovenous fistula in a 42-year-old patient who had central venous obstruction. Along with that, he had no options for a upper extremity access creation. The patient is placed supine with the leg externally rotated and knee flex. Shown here is the left leg. We made an incision roughly 4 inches in length in the upper aspect of the medial thigh. Dissection is carried down through the skin and subcutaneous tissue. We create our leg fistulas using skip incisions. Dissection is continued down through the subcutaneous tissue until the sartorius muscle is identified as demonstrated here. Sartorius muscle is retracted laterally. Careful dissection is continued until the superficial femoral artery and vein are identified. We continued our dissection and dissected free the superficial femoral artery and femoral vein. Side branches of the femoral vein are ligated with silk ties and then divided. We continued our dissection proximally to dissect free the femoral vein at the confluence of this vein with the profunda vein. Once the superficial femoral artery and femoral vein are dissected free in the proximal incision, another incision is made in the distal thigh just above the knee, roughly 4 to 5 inches in length. Dissection is then continued through the skin and subcutaneous tissue as demonstrated here. This dissection is continued between the sartorius and adductor muscles. The popliteal artery is exposed and dissected free and controlled with a vessel loop. We were careful to preserve as many vessel branches as possible. We also dissected free the femoral-popliteal vein. And the saphenous nerve was preserved. Once the femoral-popliteal vein is dissected free, both the artery and vein were controlled with vessel loop. After mobilizing an adequate length of the femoral-popliteal vein, a clamp was then placed in popliteal fossa close to the joint space. The vein is then divided with Metzenbaum scissors and then was suture ligated with a fibroproline suture. After this femoral-popliteal vein is harvested and the side branches silk tied, the vein was irrigated. The vein was then marked for orientation to be tunneled under the skin bridge. As mentioned before, we performed these leg fistulas with 2 skip incisions, allowing the anastomosis to be placed under the skin bridge in case of skin breakdown to preserve the anastomosis. A counter incision is then made on the lateral aspect of the thigh and a tunnel is created. Care is taken to make this tunnel superficial enough so it's easily accessible for dialysis access. Also, during tunneling, we transition to a deeper path as we get close to the incision. The vein is then pulled through this tunnel via the counter incision. And then is brought through this tunnel into the lower leg incision. The vein is then flushed. An appropriate size venotomy is then made in the vein. Proximal and distal control of the superficial femoral artery is then obtained. An arteriotomy is made with an 11 blade in the superficial femoral artery. Under the skin bridge, this is further extended with pot scissors. Stay sutures are then placed and an end-to-side anastomosis is constructed between the femoral vein and the superficial femoral artery. Once the anastomosis is completed, the venous clamp is removed first, followed by the distal arterial clamp, and the proximal arterial clamp is removed while temporarily occluding the distal outflow of the superficial femoral artery. A thrill is felt over the fistula. This concludes our video demonstration of creation of a left leg arteriovenous fistula for dialysis access.